Thank you so much, Claire, for joining us. I just went onto your Twitter feed this morning. For those of you who are tweeting, she's at Claire Pomeroy. and the last three tweets, 40% of Americans will develop cancer in their lifetime. That was the last tweet. The one before that was in Brazil. They're having the biggest outbreak in 40 years in yellow fever. And the one before that was after declining up until 1986, suicides have increased between 2000 and 2000. Do you ever tweet about anything pleasant?
You know, science and medical research are pleasant. They're all about hope.
Right.
They're about bringing new promise to people. And as a cancer survivor myself, the idea that medical research brings new therapies is a very positive thing. So I think it's important to raise people's awareness about the challenges out there, but it's also important to remember that science has answers.
Part of the backdrop of today is to take stock of the research and innovation system in medical sciences. We're going to have a lot of people up here talking about personalized medicine and all these things that may be just over the horizon of extraordinary strategic leaps in personal health and in the health of the country and world ostensibly. I'm interested in how you would rate the biggest threats to that ecosystem, because Lasker and you are so involved in helping to promote medical excellence and health excellence. What are the threats that ought to be top of mind to us?
As you say, medical research is really exciting right now, and I think we need to view it as a public good, and we need to invest in it. So I'd say one of the threats is, are we adequately investing in medical research? Are we adequately investing in innovation? I think another threat is that we need to make sure that we are nurturing the next generation of researchers, giving them the opportunities to have careers in science and adequately supporting them. And finally, I think it's very important that we use evidence in every decision we make in our individual lives and as a society in the policies that we set.
So how do you think that's going? I mean, I don't mean to be facetious, but I mean, we're in a time where there were protests all over the country and in many parts of the world standing up for science. It's not something you see every day. Mm-hmm. Not to knock all the sciences out. There's not every day you get people out in the, marching in the mall for science. It was kind of cool. But they must feel there's a need to. So what's your assessment of the chances you're going to get the investment, you're going to get people encouraged to go into this, and you're going to have that, a healthier fact-based system?
So I went to the March for Science, and it was very validating to be among all of those people who were advocating for science. One of my favorite signs was, "So bad even the English majors are here." But the good news is that support for medical research really is bipartisan. And you can't say that about too many things in our country today, but all the polls show that there is support across the parties, across perspectives for investing in medical research. And I think that's because each of us is touched by illness, by disease, as you said, from everything from mental illness to cancer. And each of us and all of us face the threats of the next epidemic.
If you had an opportunity to tweak anything in the ecosystem, and as I look at it, you've got companies that are sort of in pharma land, you've got researchers you're on the board of Morehouse, I know, and you're in the philanthropy. You've got doctors and patients and practitioners, but there's sort of a equation. Innovators get patents for, as I understand it, 12 years. There are cost cycles. If you were to tweak and make that more efficient, healthier, and better, what would you do?
So I would give you two answers to that. The first is it's all about partnerships. And I think that academia and government and industry and philanthropy need to come together and work together so that we can have that full spectrum of innovation from basic science that might be more often done at a university all the way through translation and then R&D development, and in fact, even implementation science, where we look at how these new discoveries are delivered to the public. So that would be my first answer, is more collaboration across the traditional silos. The second would be to invest in young people. I think the move to support STEM education in K through 12 and to make majoring in science something that's cool for our universities is absolutely essential. And we as a society send those messages to young people.
And you think that's not happening?
I think it's not happening enough. I'm very encouraged by some of the initiatives in STEM. But, you know, as a woman in science, I know that there are biases that women in science experience. Minorities have these same experiences. I think we need to make science and research inclusive. We need to get all of the brain power that we can involved in finding the answers through science.
How involved? Hello, everybody. How involved is Lasker in the genetics revolution, the genetics dimensions of advanced medical research now?
So Lasker absolutely endorses all scientific advances. I would say that it is clear to me that medicine is different because of genomics and the advances that we've made. You know, as you know, I trained as an HIV doctor.
Right.
And when I look back at the beginning of my career, there was nothing to do for HIV patients other than to really hold their hand and support them while they were dying. And medical research was fantastic in the development of new drugs. But in the beginning, we just gave every HIV patient AZT. And some of them had viruses that had gotten resistant to AZT. Well, we got genotyping that allowed us to actually know the mutations in an individual's virus, and then we could give them the right drug for them and for their virus so that they had an increased chance of responding. That ability to genotype the virus changed everything. Those are the kind of advances that we celebrate at Lasker. And I think, and I hope, that the public celebrates because, again, it changed everything in the HIV epidemic.
We were talking backstage about infectious diseases and HIV and your journey through much of that. What do you think the most important framing lessons were that would affect? I mean, this is not a done thing, infectious disease, right? We were talking about other waves of things that could come about. What do you think we've gotten right after the HIV response?
We learned a lot in the HIV epidemic. The first thing we learned was we didn't react fast enough. And many people died because we didn't react fast enough. So we need to continuously be doing science so that we're ready to respond to the next epidemic, which is inevitable. I think the second thing that we learned...
Not to interrupt, but where do you think that next epidemic will come from, given your best guess?
Well, we know that most of the new emerging diseases come from animals, so zoonoses. But the thing is, we need to be prepared because we can't predict. There's a great deal of anxiety about, you know, the next flu epidemic. There's a great deal of anxiety about what's the next zoonotic infection that comes out of, you know, South American Amazon forests or Africa. We just don't know. But we have to be prepared. The second thing we learned in the HIV epidemic is that empowered patients can change everything. And it was because of groups like ACT UP during the HIV epidemic that science moved as quickly as it did. And I think scientists learned to partner with patients during the HIV epidemic and understand that if we came together, we could actually make the advances faster. And then a third thing that we learned was new ways of getting drugs approved. The idea of rapid approval, which has been picked up now by the FDA, and there are new ways.
That's the 21st Century Cures Act.
Yeah, the 21st Century Cures Act has many mechanisms in it to get more rapid approval of drugs. Now, there's always a balance between safety and rapid approval, but when patients were dying of HIV, They said, I need access to those drugs. Let's make sure that regulations aren't getting in the way of delivering safe drugs to our patients.
Is the 21st Century Cures Act enough, or do we need to now go a level beyond that?
So the 21st Century Cures Act has great advances in it. It has many things. It has sustained funding for the NIH. It has rapid approval mechanisms, better ways to do clinical trials. There are many good things in there, but I don't think we can ever get complacent. We always need to be looking at better ways to do science, better ways to fund science, better ways to do science, making sure we have the right regulations in place. And I'll give you one example of something I think that we need to talk about, because it will come up in a subsequent panel here, which is we really need to look at all the ethical, legal, and social implications of the science that we're doing. Some people call that the ELSI, ethical, legal, and social implications. And I think sometimes we're making these great technological advances, and yet we need to have the personal and societal wisdom of how to use those advances.
So how do you get that right? Because with all due respect, and I wouldn't against it, it sounds right, the ethical, legal, social sides of science. But there's another side to it, that when information is being shared, or the need for actually more data to be shared between institutions, that it's uneven around the country, that I've heard from Sid Mukherjee and others in the cancer research area, that there's a lot of data hoarding and selfishness in the kind of Cambridge health institutions. I was talking to Bill Dalton of the former CEO of Moffitt yesterday. He said Midwest institutions tend to share more, tend to be more, commonly directed and trust each other in this, and that so a lot of the kind of data banks that are developing are in institutions not connected to sort of New England. And I'm interested in that, whether there are inhibitors because of so-called science or social and legal and ethical concerns that may actually be, in disguise, maybe self-interest.
I think we absolutely need to look at ways to tear down the walls between the silos, whether it's academic institution to academic institution. We need to look at the incentives. Academia has sometimes incentives like publish or perish, which encourage people to hold on to their own data. Industry has, the bottom line stockholder needs that sometimes cause them to hold on to data. And this goes back again, I think, to this concept that I think as a society, as members of the public, we all need to say science is for a public good. And I truly believe that most scientists go into research because they want to make a difference. They want to do good for others. When I talk to a researcher who's discovered a new therapy, say the Gleevec for chronic myelogenous leukemia, which was a cure for leukemia. When I talk to Charles Sawyers, the guy who invented that drug, his face lights up about the good that he can do for people. So I think that leadership in the institutions that you describe, every scientist, but also society needs to say, let's keep our eyes on the prize, and the prize is better health. And it's a pretty good one.
What if we made Claire Pomeroy, and we took you out of being this do-good philanthropist and made you a pharmaceutical company? And it was sort of, Pomeroy Pharmaceuticals, right? And you were out there looking at doing good, but also making money. I'm interested in this equation because I think it's very much part of this question of personalized medicine and incentives. The difference between blockbuster drugs that fix everyone and those that fix much smaller communities and address much. How do you get that equation right from a pharmaceutical company's perspective?
So, this is the challenge because industry does have a bottom line requirement to survive. And if no money, no mission, no mission, no money, right? So I think that we have to decide as a society how we want to invest in those drugs that may not be cost effective for industry. There are some interesting new models. There are nonprofits which are getting into the business of drug development, and they often partner with big pharma who have the facilities. to do that. I think there are many examples where industry has said, we understand the societal need. Perhaps the classic was the use of ivermectin, where Merck shared the ivermectin to combat river blindness in Africa. Africa would never have been able to afford to pay for that drug to treat everybody with river blindness, and they said this will be our social mission. So I think that these are the balance. Sometimes we don't look at the economics correctly, too. There are drugs that have been developed that actually cure diseases. They may look very expensive up front, but let's do the economic analysis that shows not only the suffering that they get rid of, but also the fact that we don't have the costs of treating the chronic illness.
How would you tell that story in a better way? Because I hear that often, that there are these costs saved in society, and you don't have this massive ledger book that society can say, okay, we have this ledger book, we're getting something right, you know, there's less cancer, or there's more people walking, and so there's more wellness. How do you get an orientation that's more holistic in telling that story? Because I know you're into science storytelling as part of Lasker, but I don't know what the killer app is in that.
So, in my opinion, one of the challenges in the United States in how we sort of pay for things is we pay for things in silos in the federal budget as well, right? And so there is this new concept called health in all policies. And if we actually looked at the increased economic productivity, the social services savings that curing some of these diseases will incur, if we had that holistic picture of budgeting instead of a siloed picture of budgeting, we could probably do great things. One classic example is mental illness. And so, you know, we have many new drugs for many people with mental illness, and yet we're still putting many of those people into the jail system instead of into the medical system. So one of the things that we care about at Lasker is that people understand the impact of these research advances, but also that we have equitable access in our society to research advances. And I think that is the responsibility of the public to ensure that there's equitable access to the benefits of research. But I do believe that it is also the responsibility of scientists to speak up about that.
Would you say that you're winning that battle on access, or would you say that you're expecting to have headwinds?
I would say there are some examples where we're winning, but there are many headwinds. And I hope that forums like this will motivate and inspire people to get out there and say, this is our value system in this country, that we would have equitable access to these things. I'll give you one example. We brought Mary Claire King to Morehouse School of Medicine. Mary Claire King is the woman who discovered the BRCA gene that puts you at increased risk of breast cancer. We gave her a Lasker for that. We brought her to Morehouse School of Medicine, and she's partnering there, a traditionally black, historically black School of Medicine, to make sure that research about BRCA and access to testing is happening in the African American community. That's an example of a scientist stepping up and saying, my discovery needs to be accessible to all of our society.
Cool. Going to a Lasker Prize is so cool. I just have to say, Mark Andreessen, the big investor in Silicon Valley, tweets a lot. I love his tweets. and he tweeted that most of the great innovations that will be coming out tomorrow have already been discovered and sitting on the shelf, like they were tried and shelved. And so go back and mine things. And I was fascinated by this story of AstraZeneca having worked, I have to read this, non-small cell lung cancer. Probably all of you know this, but they had a therapy for this that failed in 90% of the people that it was applied on, but it worked on 10%. And now when you go back to this notion of personalized medicine, they're resurrecting this drug to kind of deal with the 10% of it and focus it in a way that are there. I'm interested, just because you've got such a great purview of the whole scene, how many of these things have we just gotten wrong because we tried to apply to everyone, as opposed to saying, okay, 10% were sensitive to that drug in important ways, let's go back and rediscover it. So is there an era where we can just go back to the failures that actually were successes but couldn't count that way?
So the answer I say is yes and no.
Okay.
There are clearly many drugs that only worked for a subset of patients, and when we did a trial on the whole giant group, the noise of the other subsets got in the way of showing the efficacy in the specific subset. And so we do have an opportunity to go back and look at those drugs for things like orphan diseases too, right? So I think that it is very important that we go back to the things that are on the shelf and make sure that we're adequately using them. But in my opinion, it cannot be at the expense of continuing to have that pipeline filled up with new things. And at Lasker, this is one of the messages that we send, is that you have to be aware of the entire pipeline, the entire spectrum of medical research. The fundamental research doesn't pay off now. It pays off down the line, but it's the thing that feeds the translational research and the clinical research and the R&D. So yes, let's look back and make sure that we haven't overlooked some powerful drug, but let's not give up on inventing new ones.
Before I go to the audience just for a few minutes, I wanted to end on something personal with you, because in reading about you and your work, and it's so impressive what you've done, you also have a complicated past. And one of the questions I have is, how does this industry that's full of data and bigger data and systems and costs and relationships and partnerships keep people at the middle of it? You were raised in largely foster homes, you left an abusive home, and people talk about your strength as having come from that experience, that's why you keep people so dead center in the middle. What do you have to say to other big players in this ecosystem about how to keep people in the middle of these questions?
So I think when you grow up in tough circumstances, that's what forms your core values. And I think that as leaders and as scientists, we need to always keep in mind our core values. And for me, it's about helping the vulnerable. And I think science and medical research are the solution to many of our social vulnerabilities. But that's why I care so much about health disparities. That's why I care so much about access. But, science and evidence give us the potential to find the answers to these inequities. So my advice is, always go back to your core values. Know what they are, and apply them every day in every decision you make. And I hope we do that as individuals, and I hope we do that as a society.
Wonderful, thank you. Let me open the floor for questions, concerns. Yes, right here. We're going to bring you a microphone. Yes.
Hi, I'm Sandy Alsace, and thank you for your commitment to the human genome first. But what role do you see, or the influence of IBM's Watson in this whole process?
So, this is the era of big data, right? And no one scientist, no one scientific team could ever integrate all of these data points. So the ability of technology to help us see the connections in all of these data points is so powerful. So, we've gone from personalized medicine, which is finding the individual therapy, to personalized health, which is like taking this data and trying to figure out maybe even how to prevent things. And then we've progressed to this concept of systems medicine, in which we gather a whole cloud of information about you. We are going to need things like IBM Watson and technologies to synthesize that and make all of that data into real information that can be used.
But the doctors aren't very happy about that.
I don't believe that IBM Watson will ever replace your personal physician. There is both art and science to healthcare. And I think that what we're seeing now in medicine is that doctors, especially young doctors, are learning how to use technology to augment their interpersonal relationships. But nothing can ever when you're feeling vulnerable because you've been diagnosed with a severe illness, nothing can replace that connection one-on-one between a patient and their physician.
Any other quick question? Who's going to get the next Lasker Prize?
That is the one question I can't answer.
I had to ask it. Ladies and gentlemen, Claire Pomeroy, President of Lasker Foundation, thank you very, very much.
Thank you.